Okay, I'm going to keep this very short because the definitive lecture was given by my colleague earlier on today. So where shall I start for MPSs? Well, with Ollie and Kamal, two young men with similar but very different problems. As I said earlier, when things go wrong, you have to think skeletal dysplasias, you think metabolic bone disease, you have to think outside your orthopedic box. Because the lysosome is the cell recycling center. It's responsible for the enzymatic degradation of unwanted material. So if enzymes are missing, the material accumulates and it causes multi-system problems. So there are 7 commonly recognized syndromes associated with 11 enzyme deficiencies, and they give multi-system problems. The diagnosis has to be done by clinical suspicion, and there's a whole list of features. You can do a urinary screen, but for us, it's a skeletal survey that might give us the first clue. And you do lysosomal enzyme testing only when everything else is pointing towards that diagnosis. And we're looking at quite a rampant skeletal dysplasia. There are milder phenotypes, they probably do exist, so keep your eyes and ears open. And as I say, when you think skeletal dysplasia, when you think of multiple abnormal bones, think MPS. And there is treatment now for the severe type 1 MPS. You can have a hematopoietic stem cell transplant. That's a dangerous thing to do to a child, so only for the severe form, really. And enzyme replacement therapy is coming in for each of the other conditions. Oh, I'm going the wrong way. Orthopedically, we're interested in comfort, function and appearance. We want to reduce the impairment, disability and handicap and increase participation and involvement. We know that in morchios there's a lot of spinal issues as well as generalized skeletal issues, but it can be quite variable. The cervical spine, if you've got a changing gait pattern, you have to think C1, C2 subluxation. And you want to look for cord compression and signal damage, and also know that the chest and the airways are quite funny shapes. If there's a problem, early fusion with decompression is helpful, but there isn't always a problem with the cervical spine. Similarly, the thoracolumbar spine is not such a big issue in the MPS 4 patients. But as a non-spinal surgeon, I see joint laxity, limb deformity and short stature, but with normal intellect and a child who does their best to stand tall and straight. They're motivated to do well if you give them a hand. As a doctor, I do still see reduced life expectancy and a poor post-operative recovery. Many will be wheelchair-based or using walking aids. And why? Their mobility is limited because of their multi-system disease. So improving their orthopedic element may only help a bit, but that bit may be quite important. So in MPS 4, I will use guided growth to improve the mechanical axis and improve the joint alignment. And it will produce some impressively good results. But it relies on growth potential. And many of these kids with Morquio syndrome have 80% of their final height by aged 4. So if you want to grow them straight, you'd better start early. You better start early and probably do both the femur and the tibia and leave it in, if you can, for as long as you can. It does work, it does straighten the legs out, and it will improve the 6-minute walk test in our hands, and they do seem to remain more mobile. If they've got residual deformity, then I try to use a simple corrective osteotomy technique. I still favour pins and plasters quite often, but there are many ways you can skin a cat, so to speak. My knee bone is connected to my hip bone. When we looked at our group of patients, we found surprisingly little correlation between the hip position and their overall function. But there must be a relationship. The hip problems, you've got to remember, it's the cartilaginous shape that is important, and the dynamic arthrogram can be really quite useful at highlighting the abnormal soft tissues and the abnormal cartilage. I've been a little conservative with the hip pathology in Morchios, but I know that Will Mackenzie has shown me that I should be more aggressive. The reconstruction may not be as stable as you want it to be, because in Morchios there's considerable joint laxity. But there are good results, although recurrent surgery may be needed. And before you consider surgery on the Morchios, remember the cervical instability, their thoracolumbar problems, their upper and lower airway obstruction. and the fact that their joint laxity means that perioperative care with crutches, etc., may be surprisingly difficult. But Ollie is not Kamal. So what do I see when I look at Ollie, who has MPS 1? He's got stiff joints, not loose joints. He has contractures, and as a group, their IQ is a little more variable, and they certainly can have quite marked behavioural difficulties. With the carpal tunnel syndrome, we've shown in our institution that neurolysis is no better than decompression. In our hands, a trigger finger is still treated by releasing a tight pulley. We don't tend to routinely take off a slip of FDS, as has been reported in some institutions. Again, we aim for straight with our knock knees. We get them straight, we take the plates out, they grow crooked again, we put the plates back in again, and we end up straight. We've learnt that recurrence is inevitable if the skeleton is still growing, in contrast to the rickets that I mentioned earlier. So we know that knock knees are common, but that guided growth will always correct in the child who has growth remaining. In the MPS 1 and 2 hips, again, the dynamic arthrogram shows you whether the hips are reducible. It shows us the extent of the cartilaginous acetabulum, and it means that you can plan your surgery accordingly. We have to remember that pathology isn't just a snapshot. We want to see what is happening to those hips and to that child over time. And only when you get a feeling for what's happening might you understand when and what to intervene with. The MPS 1 hips are worse than the MPS 2. They have these very capacious capsules and very dysplastic acetabulae. But the anatomy can be quite variable, and you need to use whatever investigatory tools you have in order to have a full understanding of the hip. So we know there's a high rate of hip dysplasia. There will be progressive migration in most hips. The acetabular dysplasia, as we measured it, was quite variable, and overall, the MPS 1 hips were worse than the MPS 2s. So do these hips need an operation? Well, I do know that 75% will get worse on X-ray, but I don't yet know if they will have specific problems, or if the surgery that I do to address this dysplasia will actually have long-term benefits. But I am becoming more aggressive as my understanding of the condition grows. And certainly this hip reconstruction, which has worked very well symptomatically, might have been easier had I been brave enough to do it earlier. The spine deformities are complex and severe, and I'm really not going to discuss that anymore. So for Ollie and Kamal, with their multi-system disease and all the modern treatments that we have for them, we still don't quite know what the minimal, clinically important difference is that they are looking for, and in what domain of their lives. Do they want big hip, knee and ankle surgery, or do they want a speedy wheelchair that will allow them to get from A to B quickly? And sadly, there is a real lack of quality outcome data. And even more surprisingly, there's relatively little work on the indications for surgery. There's just results on the outcome radiologically, which is not exactly what I was taught to be a doctor for. So it is a changing world. Think of the MPSs, recognise it, ask for help from all your colleagues, because this par excellence is a multidisciplinary team problem. Thank you very much.
Thank you very much, Dr. Deborah, for that excellent talk. I think one question, just to conclude.
Ma'am, thanks for the nice talk. Can you share your experience of enzyme replacement therapy? Any patient whose life has been changed because of this therapy?
I think their lives are changed, but I don't think, Will may be able to say better, I don't think we really know how to define that change. For example, my patients were told that enzyme replacement would improve their neurological development. That's not so good as we thought it would be. They were told it would improve their endurance and their fatigue. I think that probably is true. But I don't think we've really yet evaluated exactly how helpful enzyme is on its own.
Which subtype have you treated for?
Sorry?
Which subtype of MPS?
For the 1s, 2s and 4s is what we've got most experience in.
Thank you.
Well, thank you very much, Dr. Deborah. I thank all the faculty for their participation and the audience for their active interactions. I would also like to acknowledge Pega Medical for their assistance in conducting this ICL. Thank you.
The next session will start in exactly 5 minutes. So please grab a cup of coffee and come back.
It was everything about. Yeah, I'm coming.
तो नोट लिया होगा सर